Hi everyone, this is LK. Welcome to our channel. Today we are going to discuss about scapula. So what is the other name for scapula? That is called shoulder blade. Usually we'll call it as a shoulder blade. So in this scapula, so we can remember the three important points to identify the side determination. So to identify the side determination, we have to remember the first point. We have to keep this is that called glenoid cavity or glenoid angle that should be always lateral, either this side or maybe this side. You have to keep like this. And one more important second point, that is that in dorsal aspect, this is called dorsal surface. The dorsal aspect, we are having a projection, shelf like bony projection called spinous process. This should be always present in the dorsal aspect. And the second point we have to keep. The third point, when you are looking here, so we have the three borders in the scapula. In this case, that superior border which always carries a notch, that is called suprascapular notch. Here it is somewhat different. In other scapula, you can see here there is a notch that is called suprascapular notch. So in this 3 point, we have to remember the first point. To remember the basic features of the scapula, we have to remember the number 233. What is meant by 233? It means the scapula has two surfaces, three borders, and three angles, and three processes. With this, we can conclude the number that is 233. Now we will discuss first about the surfaces. How many surfaces the scapula has? Two surfaces. One is called ventral surface, otherwise known as costal surface, because it is facing towards the rib. Another one is called dorsal surface. As I said earlier, it is having the spinous process. With this, we can identify this is the dorsal surface. And what is the feature of that costal surface? It is concave in nature, concave forward, and it is having that concavity. No, this concavity is called subscapular fossa. Why it is called like this? Because it is giving an attachment origin for the muscle called subscapularis muscle. In this costal surface, scapula will have 2 or 3 bony longitudinal markings. It will give attachment for fascia covering the subscapularis muscle. Now we are moving to the dorsal surface. As I said earlier, dorsal surface will have a shelf-like projection called spinous process. In this spinous process, dividing the entire dorsal surface into two, that above to the spine, that is called supraspinous fossa, below to the spine, that is called infraspinous fossa. And both supraspinous fossa and infraspinous fossa will be connected together by spinoglenoid notch. This is the spinous process and this is the glenoid cavity. Between this, the notch is called spinoglenoid notch. Now moving to the borders. Scapula has three borders: superior border, lateral border, medial border. The superior border, which is extending from the superior angle to the lateral angle. So in the superior border, when you are tracing this close to the lateral angle, it will have the notch that is called suprascapular notch. And next to this, we will have a crow beak-like projection called coracoid process. And the lateral border. Lateral border is extending from the lateral angle, otherwise known as glenoidal angle, to inferior angle. And this is called the thick. It is the thickest border in the scapula, a rod-like thickest border. And one more border, that is medial border, which is extending from superior angle to inferior angle. This is the medial border. Medial border, superior border, and the lateral border. In this three border, lateral border, as I said, it is thick rod-like, and it acts as a fulcrum for the serratus anterior muscle during overarm abduction. Now moving to the angle. It has three angles. First, lateral angle, otherwise known as glenoid angle. Why it is called glenoid angle? Because it has the cavity-like structure that is called glenoid cavity. That's what it is called, glenoid angle. And one more thing is, this is called superior angle. And which is down, that is called inferior angle. There are three angles in the scapula. Now moving to the process. As I said, scapula has three processes. One is the shelf-like projection, that is called spinous process. This spinous process has two borders. One is, this is the front, am I right? So this is the front, and this is called anterior border, which is attached to the dorsal surface of the scapula, which is attached to the dorsal surface of scapula, that is called anterior border, and which is freely present, that is called posterior border. This posterior border has two lips. One is upper lip, another one is lower lip. This posterior border, otherwise known as crest of the spine of the scapula. I am repeating again. So the spinous process of the scapula has two borders. One is anterior border, which is attached with the dorsal surface of scapula, and one other is the posterior border, which is having two lips, upper lip and the lower lip. And this posterior border, otherwise known as crest of the spine of the scapula. Moving to the next process, that is acromion process. Acromion process is nothing but the continuation of the spinous process. It is extending here, and it is flat in nature, and it has two borders and two surfaces: medial border, lateral border, superior surface, and the inferior surface. So close to the tip, it is having a facet. You can see the facet. This facet will helpful for the attachments of the clavicle to form the acromioclavicular joint. The third process, that is nothing but coracoid process. The coracoid process, which is crow beak-like appearance, this is embryologically important, and it is the example of atavistic epiphysis. And what is meant by atavistic epiphysis? This is fused with the scapula, but in some lower animals, especially reptiles, this coracoid process is the separate bone. So in the lower animal, so those bones which is presenting separately, and in the human, it is fused with some other bone. That kind of epiphysis is called atavistic epiphysis. And one more example for this, we are having os trigonum, which is presenting in the talus of the foot bones. That is called os trigonum. That is also one of the example for atavistic epiphysis. This coracoid process has two borders. One is medial border, another one is lateral border, and two surfaces, superior surface and the inferior surface, and one tip. Now we will discuss about the attachments. As I said, costal surface, medial two-third will give origin for subscapularis muscle, and dorsal surface, same way, that medial two-third of the supraspinous fossa gives origin for supraspinatus muscle. The medial two-third of the infraspinous fossa gives origin for infraspinatus muscle. And when we are moving to the lateral border, now moving to the ventral aspect of the medial border, it gives insertion for one important muscle, that is called serratus anterior muscle, which is having 8 digitations. In this case, first digitation from superior angle to the exactly opposite to the spine of scapula, we are having a first digitation. And second and third digitation, first digitation will be here, and second and third digitation will extending from root of the spine to the inferior angle, and the rest of the 5 digitation which is attached to the inferior angle. Now in this 8 digitation, first angle is attaching from superior angle to the root of the spine, second digitation is attached close to that second from here to here, second and third digitation, and rest of the 5 digitation will attach in the inferior angle of the scapula. Now moving to the spine. In the spine, as I said, the dorsal border, posterior border has two lip. One is upper lip, one is the lower lip. And that upper lip, it gives insertion for trapezius, as well as is this extending to the medial border of the acromion process of scapula. When the trapezius is extending down, and it will attach here, and there is a tubercle. This is called deltoid tubercle. Even though it is having the deltoid name as a deltoid tubercle, it gives insertion for trapezius, not for the deltoid. Remember, this is an important point. And this bony prominence is called deltoid tubercle. Even though it is having the name called deltoid tubercle, it gives insertion for trapezius, not for the deltoid. Now, the same way, the lower border of the spine of the scapula gives origin for deltoid. And the same way, lateral border of acromion process gives origin for deltoid. In this case, we have to remember that lateral border of acromion process fibers, because this fiber is multipennate. That intermediate fibers, this is the intermediate fiber. Anterior fibers from the clavicle, intermediate from the acromion process, posterior fibers from the spine of the scapula. These intermediate fibers are multipennate in nature. We have to remember this point. Now moving to the coracoid process. In this coracoid process, anterior border and superior surface. Anterior border and superior surface gives insertion for pectoralis minor muscle. And the tip, which is laterally and medially. Laterally, it gives biceps brachii. Medially, it gives origin for coracobrachialis muscle. Laterally, it gives origin for biceps brachii, which head, short head of biceps brachii, and medially, it gives origin for coracobrachialis muscle. Now moving to the lateral border. Lateral border. This lateral border bears an important ligament which is making an arch between here to here. That is called coracoacromial arch. The coracoacromial arch is formed by coracoid process, acromion process, and the ligament. That is called coracoacromial ligament from the lateral border to the acromion process, close to the tip of the acromion process. These three structures, acromion process, coracoid process, coracoacromial ligament, these three together called coracoacromial arch, which is the important protective structure in the shoulder joint. And one more in the superior surface. So close to the root, we will have an attachment of conoid part of coracoclavicular ligament. The same way here we are having a attachment of trapezoid part of coracoclavicular ligament. And close to this root we are having a coracohumeral ligament. Around the facet, it will give attachment for capsular ligament of acromioclavicular joint. The same way here, around the glenoid cavity, it will give attachment for fibrous capsule of the shoulder joint. In this glenoid cavity, we are having two important tubercle. One is supraglenoid tubercle, which is above, and infraglenoid tubercle, which is below. It is supraglenoid tubercle, which is giving origin for long head of biceps brachii muscle. The same way, infraglenoid tubercle, which is giving origin for long head of triceps brachii muscle. In the lateral border, the rough strips will be there. In this upper two-third, there are two slips. One is in the above, one is in the below. These two slips of origin of teres minor muscle. In that lateral border, dorsal aspect, rough strips will be there. In this rough strips, it will gives origin for upper two-third, gives origin for teres minor muscle. One is above and this one is below. there are two strips will be. Between these two slips, there is an artery which is winding around the lateral border of scapula. That is called circumflex scapular artery. And now moving to the medial border. And what is the difference between lateral border and medial border? The dorsal aspect, we have to remember, lateral border is that origin border, medial border is the insertion border in dorsal aspect only. I am not telling about the costellar surface, I am telling about the dorsal aspect. The medial border is the insertion border, lateral border is the origin border. As I said, the upper 2/3 it is giving origin for teres minor by 2 slips, and lower 1/3 gives origin for teres major muscle. This upper 2/3 which is dividing into 2 slips by teres minor muscle, and below will be teres major muscle. The medial border, as I said, it is an insertion border. What are the insertion? The medial border, which is having 3 parts, from the superior angle to the root of the spine, exactly opposite to the root of the spine, and from the root of the spine to the inferior angle. So we have to remember that insertion border. What are the muscles inserting here? That one is from the superior angle to the root of the spine, that is levator scapulae, and exactly opposite to the root of the spine there is a triangular area which gives insertion for rhomboides minor muscle. From this root of the spine to the inferior angle, that will give insertion for rhomboides major muscle, and the inferior angle it will give origin for latissimus, few fibers of latissimus dorsi muscle, inferior angle. Now moving to the superior border. The superior border, close to the suprascapular notch, it will give attachment for inferior belly of homohyoid muscle, which is the muscle of the neck. Close to the lateral angle, it bears the notch, that is called suprascapular notch, and in this notch is converted into a suprascapular canal by a ligament that is attaching between this edge to here, that is called transverse suprascapular ligament or transverse scapular ligament. And once it is converted into a tunnel, and one structure is passing below to this and some structure is passing above to this, and what structure passing within the canal? That is nothing but suprascapular nerve. You have to remember N, nerve for navy. Navy will always goes deeper. The C, it will always go to deeper. We have to remember nerve will go deeper, and once we remember about the nerve, rest of the vessels, suprascapular vessels, will go above that ligament. We have to remember this is a suprascapular transverse ligament, and the nerve which is going below to that ligament, and the vessels which is going above to the ligaments. Now moving to the angle. Angles, we have to remember there is a lateral angle, the important angle of the scapula, that is nothing but glenoid angle or lateral angle. The glenoid angle which is having the ovoid shaped cavity, that is called glenoid cavity, which is surrounded by or which is limited by that fibrocartilaginous rim, that is called glenoid labrum, and which is making the cavity into deeper, and the head of the humerus which is making that cavity into deeper, head of the humerus is going to articulate, and which gives the support for the head of the humerus. And this is the superior angle which will give a insertion for levator scapulae muscle from here to here. The same way inferior angle, it will give origin for latissimus dorsi. Now moving to the clinical. We have to remember the scapula, there are 3 clinical importance. One is winging of scapula. This is because of 2 important parallax of muscle, and there are 2 types of winging of scapula. One is medial winging of scapula, another one is lateral winging of scapula. It means, for example, the scapula like this. If it is a medial winging, this is happening because of the parallax of serratus anterior muscle, and in this case, while doing that of the scapula, and this becomes medial border become more prominent. The back, the medial border become more prominent. This is because of the paralysis of serratus anterior muscle, because of the injury to the long thoracic nerve. And one more thing is lateral winging of scapula. Lateral border will become more prominent. This is because of fibrous paralysis of trapezius. Trapezius paralysis means the lateral border become more prominent. This is called lateral winging of scapula. The second important clinical, that is congenital anomaly. So usually, as I said, that anterior scap surface become concave. In some cases, what will happen? The scapula become more concave. It become more curved in nature. That is called scapoid scapula. That is called scapoid scapula. The third important thing, that is also congenital anomaly, that is nothing but Sprengel's deformity. Sprengel's deformity. That is nothing but usually during development in embryological life, the scapula will develop from the neck region. When the development continues, that scapula will migrate towards the thoracic cavity. Sometimes what will happen? This migration becomes absent. The scapula will remain same with the cervical bones. And the scapula will be in the cervical region. This deformity is called Sprengel's deformity of the scapula. This is the three clinical importance we have to remember about the scapula. One is the winging of scapula, both medial winging because of the paralysis of the sertus anterior muscle, and one other one is lateral winging of scapula because of the paralysis of the trapezius muscle. Second important clinical is the concavity of the scapula become more, and that is called scapoid scapula. The third one is Sprengel's deformity, where the scapula fails to migrate from the neck to the thoracic region. That is called Sprengel's deformity. If you like the video, like, share and subscribe. Thank you.